So good morning, everyone. First of all, I would like to thank you very much for inviting me for this meeting. It's quite inspiring and to hear all these talks. Unlike the other talks you heard yesterday and today, I'm not talking about science here. I'm talking more about an art, which is surgery. We surgeons, we like a bit of history. I don't know whether you can see the picture in the background, but this is Virchow, who first person in 1864 who described this tumor and actually thought it's a kind of glioma. And since then, there have been quite a few time points in neuroblastoma till 1957, which they start to detect the catecholamines in the urine, and after that, it's just science has exploded since. I'm not going to bore you with the background because we all know about the background, and I think we had an overview yesterday. But this is the typical blue round cell appearance which we see, which we actually not just see in neuroblastoma, but we see in other pediatric tumors, including Wilms tumors, Ewing sarcomas, etc. We're still seeing the same kind of figures after so many years. The mortality related to neuroblastoma out of all the pediatric tumors are still relatively significant for such a relatively rare tumor as well. So why is neuroblastoma different to other pediatric tumor we see? In general, because there is a variation in the primary site of origin. Not like Wilms tumor comes from the kidney, neuroblastoma comes from different places. The metastatic burden is very common, and commonly they secrete active metabolites as well. But why is it different for us as surgeons? I mean, I operate on different type of tumors here, but neuroblastoma is different. For one important reason, surgical capsule can be violated. Generally, if you are an oncology surgeon, a cancer surgeon, very important when you take the tumor out, you take it within the capsule. So in Wilms tumor, you have to make sure you don't violate this capsule. You don't want to spill the tumor cells. Neuroblastoma is different, which I'm going to be coming to that later on, how important is surgery in neuroblastoma. And interestingly, in localized tumor, there's actually good outcome, even if you leave some tumor behind. Which, back to the point we all know, that the outcome significantly actually relying on the biology of the tumor. Regarding the sites, I mean, it comes from the sympathetic kind of system. It's a sympathetic kind of system tumor. So if you look, it goes up along the whole way from the spine down to the paraspinal. Adrenal gland is a very important site and goes down to the pelvis along the whole way. So from the point of the compartments, can happen in the neck, mediastinum, retroperitoneum, or in the pelvis as well. This is just more or less the common surgical field we see. This is the main blood vessel, the aorta, and you have the kidneys on both sides, and you can see how extensive is the sympathetic system around the vessels. And that explains why, by nature, neuroblastoma is usually encasing these vessels, because just the way it's created. Presentation of neuroblastoma can be variable, abdominal mass, not uncommonly have a child who's unwell, have some investigation, and neuroblastoma is diagnosed. Horner syndrome can be actually a presentation and can be a complication of surgery, especially in the chest when we operate. So people who are not familiar with Horner syndrome, they have constricted pupil, ptosis, and quite dry face on the side of the disease. In surgery, staging of the tumor is quite important. But in neuroblastoma surgery is very confusing as well, because at least there's 6 different staging systems along the years, and every time we try to look at the staging system, we get more and more confused. And this, I mean, in a very simplistic way, in oncology, you stage the tumor, 1 for surgery and 2 for outcome, but it just doesn't work like that for neuroblastoma. It's just more confusing for us. This is a very busy slide. I love it, but actually, this is what it's all about. It's about the INS system, which goes from the stage 1, stage 4, and 4S. A very quick word here about stage 4S neuroblastoma. It's quite uncommon. We see it obviously under the age of 1, and although we don't operate at all, but there is actually a very small, not small, there's a significant role of surgery sometimes if the tumor is infiltrating the liver, creating what we call compartment syndrome. So what we end up doing is opening a big cut in the tummy and putting this bag, which we call a silo, which gives some time for the tumor to shrink, and then after that, eventually we remove that. Not very common we do that anyway. The other thing about 4S neuroblastoma is it's got a very good outcome in relation to the other tumors as well. I'm not going to bore you with the risk groups which we all know, but what I want to get at is, again, these slides are quite busy for me. We're very simple people here. We leave that to the oncologist to do the risk. It's just I want to look at this. It's the different outcome when it comes to mortality and survival between the different groups of neuroblastoma. So, which is still very challenging in that group. Role of the surgeons. What's the role of the surgeon in neuroblastoma? Cutting? Yes, but before that, we are a very important member of the core MDT. We share the decision with the oncologist, and I like to think that they share the decision with us as well. At the same time, we're actually part of the team. We look after the child. So we're not just come, do the operation, and then leave the rest of the care to the oncologist and the rest of the team. Actually, we are an active members of the team. We do look after the child. So, and that's what surgeons should do, not just coming and do the operation and go. So, the first active involvement of the surgeon with the team is actually biopsying this tumor. It's very important to biopsy the tumors in neuroblastoma, and we all know why. Insertion of lines, people often overlook that. The majority of the line used for chemotherapy, at least in the UK, still actually put by the surgeon. So quite often, the contact of the parents with the surgeon, not just at the time of surgery, taking the tumor out, actually before that, putting the lines in as well. And then surgical resection of the tumor. So this is the main, obviously, work we do. Why is biopsy required? Histology, genetics, and recently tissue banking, which is quite important because that's the future now. We need to store bits of the tumor, for all the clever therapy, which is hopefully going to evolve in the future. And again, recently, there's more and more discussion that in recurrent tumors, or especially local recurrence, there has been recent talks in that we need to go back and biopsy that because the biology can change. How do you do it? The traditional way in biopsy neuroblastoma is actually open surgery. When I started to train in pediatric surgery, and I was lucky to be trained by a very eminent surgeon in Leeds, all the biopsies we've done was an open surgery. So relatively big operation, child comes to theatre, put them to sleep, reasonable cut, take a chunk of the tumor, risk of bleeding is significant. And that's how we did it. And things evolved the last 10 years. We start to do keyhole surgery, especially if the tumor is in the chest. We can't get into that easily. We use the camera under guidance, give us a good image, take a chunk of the tumor. However, the most common way now is the needle biopsy, which either commonly done under ultrasound guidance or CT guidance, mainly done by the radiologist. This is the core needle we use. There's different size and length, but the commonest one we use is actually 14 or 16. And they're all obviously different manufacturer, but different mechanism to fire and all that. They're quite scary actually when you hold it in your hand. When you fire it, the clicking sound is very scary. So I remember the first time I went to theatre to watch my boss doing it, it scared the hell out of me. The way it's going in and out, to try it in your hand first. This is a recent study by the Liverpool group. They just looked at the evolving pattern of biopsy in neuroblastoma. They looked at 39 patients, almost half done open, half done needle core, which is mainly recently. And they had one significant bleed or complication. It was actually mainly from the open group, which actually shows that doing cores is much better. And interestingly, they showed all had adequate tissue. So it doesn't matter whether you do an open or a core biopsy, you get enough tissue or not. Which put the question, what's the magic number of cores we need to take? And that's been debated, because I was in the SIOPEN meeting recently and we've been discussing the draft of the high-risk study, and there was guidelines for biopsy. There's no details. There's no guidelines, really. And part of the survey which I've done, I've asked the surgeons how many do they think is enough. We know, and this is all like common knowledge, but there's no actual evidence base that in tumors like sarcoma or Wilms tumor, which some of us still biopsy, about 4 cores are enough. While in neuroblastoma, the majority agreed that 6 to 8 is the magic number. However, in Newcastle, we take 10. Some centers, I think, not wrong to say, Great Ormond take more than 10 sometimes. That's what I've been told. Anyway, but how many is actually enough? I've done a recent audit, local audit in the hospital, and I looked at the data, actually the cytogenetics receive, how many cores they get. And to my surprise, they only get 1 or 2 cores. So I know that it's recorded in the operation sheet that take about 10 cores, for example, and they only receive 2, and the rest, the histopathologist is looking at them. And without, again, evidence base, it sounds like it's the length of the core is the magic thing. It's not how many do you have. And when we looked at it, and we'll probably be looking to make it a proper study and publish it at one stage, that you need about 2.5 centimeter length of core to get enough. Because when we looked at the data, and when the length was less than 10 millimeters, they usually said not enough for biology. And then the new, I wouldn't say challenge, but the new thing coming to us is tumor banking now. And then again, ethically, how many do we need to take? Are we exposing, say, if we say the magic number required for diagnosis and look at the prognosis, etc., it's about 6 or 8. If we take, say, 12 cores and we end up producing more morbidity here, is that ethical? And I think this is a few things that needs to be discussed at one stage, because it's becoming part of the neuroblastoma management now. The other issue with the core biopsy is, which is in some tumors, you do a core, it comes back as on the benign spectrum, but actually, is there any malignant spots in the tumor which the core has missed? Occasionally, my colleague, the oncology colleague, will say, actually, in this tumor, we need to do more like an excision biopsy, because we need to look at the biology of the whole tumor, not just the part which actually showing that it is benign. So, which we occasionally call it debulking here. So again, there's no black and white here, but as overall, core biopsies are more than enough at the moment. Very quickly, I'm going to just touch on the Cvc insertion. These are the two commonest types of line we use in neuroblastoma in our centers. So we've got I don't know if they can see it well or not. This is the double lumen Hickman, which is majority of patients when they come, they get this inserted. And then when the decision about stem cell retrieval is established, we usually change it to what we call the apheresis line, which is basically a hemodialysis line. Because the flow in these lines, when they get attached to the machine, they're quite high, so you can't use these ones. Years ago, there was a move in our center to put just apheresis line for everybody, but they're awkward to put in. They're not as easy as these ones. It's just because there's the fixed lengths. This one you just very easily can adjust the length, just cut it in theta and put it in the child. But these one are fixed kind of length, so it's very difficult to adjust where it is. I mean, I should just show you that for a second. This is obviously a magnified image, but in a child, we're talking about less than a centimeter. The tip needs to be sitting in the heart in a very specific place. So you have to be quite accurate to make sure, because you need the line to last, to work. So you don't want to put a line which causes significant problem to the child, that you'll be in and out of theater and changing. And then after a while, you run out of options because of the veins. So back to when we used to put the apheresis lines years ago, we changed the practice again because we used to get a lot of problem with them, and we audited that and we ended up changing them. So what we tend to do now to put the Hickman, and when we decide about the stem cell, we put just a temporary apheresis line, which short anesthetic, put it in the groin, lasts for 2 or 3 days, and you take it out easily after that. You don't need anesthetic to take them out. While these lines, if you want to take them out, you need anesthetic again. This is the figure in my center. Traditionally, as surgeon, we used to do a cut in the neck, find the vein, put the line in. However, we have moved away from that, and the majority all gets put under ultrasound guidance. So me as a surgeon had to learn a different skill, which is actually a radiology skill. Get an ultrasound, aim for the vein, put it under guidance with the X-ray. So things have changed. I'm not going to be talking a lot about it, but actually there's a lot of advantage using that approach rather than the open, because you can use the vein on and on again 10, 15 times, while the open approach you use once or twice, and the vein is knackered after that. And there is a lot of literature coming to support that ultrasound guidance is much better than the open. This is just a quick diagram to show where we put the line. It's basically the commonest is the internal jugular vein, because that's the easiest access, lasts longer, but there is other alternative, like the subclavian approach, which is just below the collarbone here. Occasionally we put something called the brachiocephalic as well if this is not available. But this is the commonest places we put the line. Okay. Well, we'll move away from the lines now and then back to surgery. What is the role of surgery in neuroblastoma in general? One, spinal decompression. There is some talks about does it have a role of subclonus, myoclonus. Certainly in my center, Professor Twiddle is very keen if you have a localized tumor and the child has obsoclonus, myoclonus, to remove the tumor because there is some emerging evidence, and the oncologists here are sitting watching me, that this actually improves it. Biopsy and debulking, and then resection of the tumor, and we'll talk about it in a second. Neuroblastoma surgery. Big operation. One of the major operations we do in pediatric surgery. When I have a case, it takes a lot of time for me reviewing the scan on my own. Go to the radiologist with my colleagues. Go back. Dream about it sometimes. It's just because you have to think about it and you want to know what you're going to do. And then every surgeon will have particular approach he likes. Like if you talk to Professor Lacquaglia in Sloan Kettering, he likes the what we call thoracoabdominal approach. He goes from the side into the chest and the abdomen. I prefer the subcostal, sometimes the rooftop approach. Whatever it is, use the same and stick to it. It's just the familiarity is very important in surgery. Because if you do the same thing again and again, it becomes subcortical. So you don't have to think about it much because you preserve your concentration actually to the actual tumor, not to think about what is the first step you're going to do. It is quite important here. Anesthetist, we are a team, we're all together. Very important to have the same people doing the operation with you all the time. You understand each other. I don't have to talk when I'm operating. The anesthetist can actually read my body language. Am I in trouble? I don't have to say I'm in trouble. They can just sometimes read it. Different surgeons have different ways of responding to being in trouble. One of my colleagues starts swearing. Other colleagues become very, very polite in theatre, very formal. Theatre team, again, part of the team, not just the anesthetist. You have the same people operating with you every time because you don't have to ask. Usually, when I have Margaret with me, my hands are out. She knows what I want. I don't have to say what I want. She just gives me the right instrument in my hand. I'm not very good in being vocal, so you need someone who actually knows how do you work. And often, when you have a very experienced staff with you, they can see what is happening, and they give you actually what you need, not what you want. You need to have good assistance. And now there is a move away from the single surgeon approach in operating on neuroblastoma. We operate in pairs now. In my center, there's 2 of us. We operate, and we always operate together. Someone will be leading, the other will be helping. It's a long, tedious operation. So you need to take a break. Your colleagues will do a little bit till you come back, and vice versa, and so on. There is no pride in surgery, by the way. You do what is right for the patient. And unfortunately, surgeons have some pride. So you need to take a step back sometimes and evaluate and say, am I doing right here? Do I need to stop? Very important. Very good night's sleep before surgery. You need to be really focused. It's like going to an exam every time you operate. You need to sleep. You need to be fresh. No distraction in the morning. Every one of us will have some rituals before they go and operate. Footballers, before the matches, have some rituals. I have my own rituals. Nice cup of coffee, sit for about good 10, 15 minutes, coffee room. Don't talk to anybody, just chill. Wait till I get called when they're ready and go in. When it comes to the actual surgery itself, there is some rules or principles we like to stick. Important to define the compartment means like, is it just in the chest, or is it in the abdomen, or is it both? So, and that will decide on your approach. Like any surgery, exposure is very important. You need to see what you're doing. You can't just operate in the dark. And I'm not joking here. You need to have everything in front of you. You can't just oversee something there. It is quite important. It can be focused, because the field is quite small, but you need to make sure you get the bigger picture. Exposure is very important. Anatomy is very important. You need to know which bit you've got in your hand. And it's not easy sometimes when you have a big bulk of something sitting there, you don't know what's underneath. Most important thing, and this is just for neuroblastoma surgery, what we call establishing a subadventitial plane of dissection. Mr. Kiley, a very eminent surgeon, Great Ormond Street, who's just retired, he was like a pioneer in this. Surgery, actually, there's nothing really new over the last 50, 60 years, but actually, what was a big change in the neuroblastoma surgery is this. And I'll explain to you. The anatomy of the blood vessel, either artery or vein, you've got different layers. Starts from the intima, which is the lining, and you go out till you have this layer there, which is the adventitia. Vascular surgeons know this layer very well. Because what is happening is the tumor is usually stuck onto this layer. But once you get between that, it lifts up. And this is very, very important. So anyone who operates on neuroblastoma knows this. Planning. This involves, obviously, the imaging and the timing of surgery. I'm going to have a quick talk about the timing of surgery at the end, but the planning starts weeks before surgery. I tend to meet the parents when they come to our day ward, have a chat with them a week or two before. It's actually a consent process, but I started early because often there's a lot to digest, so it gives them time to think about it. And I operate usually on a Monday as well, so the parents usually come the day before. I try to meet them, spend some time in the evening, have a good chat, and following morning come again. Any quick questions? No. And explain that usually, because the common question by the parents is obviously about the complication, etc. How long does it take? It's a long operation, but I usually say, which is the truth, taking long doesn't mean that it's actually something is going wrong, but it's just, we are just simply taking our time. Every operation is different to the other. There's no tumor similar to the other. They're all different. And then usually after that, I was just chatting to Nick this morning about coming and talking to parents after that. Usually I say, I'll come and talk to you afterwards. That doesn't mean something went wrong or anything. It's just the usual discussion. Very, very quickly, I'm just going to talk about imaging because it's quite relevant to us, to surgeon. MRI is the preferred modality. However, CT is useful because not uncommonly, and again, without talking about evidence from the literature or anything like that, when there is calcification, you don't often see it on the MRI. And occasionally, I would go and nag my radiologist and say, I want a CT, and I want it with angio because I need to see exactly where the blood vessels are. Not often you can see that on the MRI very well. And I'll tell you a secret. We are, as a surgeons, we prefer CT. We read CT better than MRIs. We're just simple people. And we find CT easier, actually, to read just before surgery. MIBG is obviously part of the workup, and relatively new, the SPECT CT. I find it useful, and especially in recent cases I've done that when we've done the SPECT CT, you can actually have a better identification when you superimpose the picture over the MIBG picture over the CT scan. I'm very quickly going to touch on the IDRFs because there's something recently. These are the surgical risk factor identified by the imaging. It's important at the diagnosis and before any treatment. And the advantages allow the constant and uniform reporting. So in a way, it's just a way to warn the surgeon what they're expecting, and also it's a prognostic factor. However, they're not contraindication for surgery. This is the famous paper a few years ago which highlighted the IDRF. This is just to explain what does it mean. If you have a tumor which is not encasing the vessel by less than 50%, that's no IDRF. While if it's more than that, that's significant, which basically has implication on the surgery. And again, this is just in real imaging. This just shows the tumor and the vessels in relation here. Okay. Again, vessels going through the tumor. So that's significant IDRF. Another example in the chest in relation to the airway, trachea. Again, you can see. INRG staging makes it more simpler to us. It's either an L1 or L2 tumor. Either it's a localized or we have one or more IDRF. Incisions, again, we talked about it before. And the view and the exposure again, which is important because you retract the bowel away, and this is what you get in the retroperitoneum. I'm talking about the abdomen, which is the commonly operative field. So you start your dissection from below, and then open the tumor up, and then when it's opened up, you end up getting, you need to get into the subadventitial plane, and then you open up and expose the major blood vessels there. It's not a surgery for the faint-hearted. Important question, when do you stop? Two things. You're risking the life or important organs at risk. However, not uncommonly, phone a friend. I'm on the phone to my colleagues, Quentin, Debbie. This is a situation. Where we go from here? And most of oncologists, I think, they have a good contact with the surgeons. Intraoperative. Very important during the operation. Have a break. It's a 10 hours operation sometimes. You have to be focused every single minute you operate. So you need a break from time to time. After surgery, they all go to PICU or high dependency. I put red on pain management here because it's very, very important. I'm not saying people overlook that, but it's not just you operate on the child. You need to make sure the child is really comfortable after that. Because it's not just, it's humane to do that, but it improves your outcomes. They recover quicker. They're much better. Their experience is better. And they go back to the treatment again. Main complications we have is, again, bowel ischemia. This is a very annoying complication. Chyloscystitis or chylothorax. You damage the lymphatic duct in the tummy or the chest. You end up with chyle leak in the tummy weeks and weeks and weeks. It's not dangerous, but it delays the treatment. And you want to get this child back very quickly to get the treatment. Complications depends where you read about, but about a third you can get complication. A nephrectomy up to 8% from the different literature. Overall, long-term renal ischemia is about 2.5%. Operative mortality, thankfully, very low, despite it's a very big operation. This is aside from unpublished data, and you can see it is very low. Thankfully, for example, in Newcastle, the last 8 years, we didn't have a single 30 days operative mortality. Role of surgery in localized neuroblastoma, very important. It goes back to 1988. Surgery is relevant. However, and this obviously has been confirmed recently by the recent German study saying that actually surgery is quite important, improves the survival here. Which put the question, does aggressive surgery matter? There's quite a bit of controversy about it, but this is a very good paper from Liverpool again. It was a meta-analysis. And basically what they showed, gross total resection has an advantage in stage 3 only, while stage 4, it doesn't improve the survival, but it has some advantage in the event-free survival. Very quickly, a touch on MIS, which is minimally invasive surgery, neuroblastoma. There's more and more series about it now, and it is safe. However, still for the patient without IDRF, I'll be very nervous to do minimal access surgery in patients with IDRF because of just the way we dissect the vessel and all that. However, there is more and more talk about it and how to utilize it. I've just summarized the surgical kind of issue. One, aggressive versus non-aggressive in high risk, still a big question. What is actually complete tumor resection? And most of the surgeons agree that more than 90%. This is not really complete, is it? And what is percent? How do you measure percent? Is it the surgeon's perception, or is it the imaging after the resection? Timing of surgery, it's quite relevant. Do you do it after 2 cycles or after 4 cycles? We know from our experience, too much chemotherapy, when you come and operate, is really, really stuck, absolutely frozen there. Do we need to operate earlier? I think that's a very important surgical question. Consistency in reporting our notes. What is the challenges for surgery in the UK? First of all, still relatively small numbers, about 100 cases a year to operate on, so the experience is not great. Guess how many centers operating on neuroblastoma in the UK? Just guess a number. Some people will know in the audience. Guess? $18. So the question, do we need to start thinking about the Dutch model? Netherlands, they used to have 4 centers, 20 million population. They moved into 1 center. Future, again, answering the same questions again, which this is almost there. We need money to fund our surgical question, which unfortunately, I would say the most of the money going for the oncological questions. The next is we need a UK at least surgical database, record all our operation and review them every year, every 5 years to see how good we are. I mean, does it matter 18 centers operating or 1, 5? New approaches, robotic surgery. Adult surgery, they have robotic surgery is coming, improve outcomes, some like prostate cancer. Thank you very much.